Okay. Okay. Good afternoon and welcome to Tohoku University webinar. In this webinar, Tohoku University, one of Japanese leading universities, discuss important issues with its faculty. My name is Onoda, a professor in the Department of Architecture, Tohoku University. It's my great pleasure to serve as your moderator. There have many signs recently that the second wave of the COVID-19 epidemic could be on horizon. The science of planning and management is therefore urgently needed to help us to build a new society that is capable of coexist with the virus. Today, Professor David Alexander, one of the originators of modern disaster science, will speak. He was an early advocate of integrating the social and natural science in disaster response. The title of his speech today is a key aspect of emergency planning and management for pandemics. So first of all, I would like you to hear a welcome speech from Professor Toshiya Ueki, the Executive Vice President of Tohoku University, who has given us these opportunities. So please, Professor Ueki, please.
Okay, thank you, Mr. Onoda. Hello, everyone. My name is Toshiya Ueki, Executive Vice President of Tohoku University. I am very delighted that you all joined us for today's webinar with Professor David Alexander from the Institute for Risk and Disaster Reduction at University College London. UCL and Tohoku University first signed an academic exchange agreement in 2013. Our two universities are currently focusing our collaborations mainly for 5 areas: life science, material science, disaster science, data science, and higher education. Last year, our two universities also launched our matching fund program to further support collaboration between our two universities. 7 projects, including this interdisciplinary research, were selected and are being supported under this program in the 5 key areas. In October last year, UCL President and Provost Professor Michael Arthur visited our Tohoku University and chaired our International Advisory Board and succeeded bringing together and summarizing a range of valuable insights from many diverse experts. The academic exchange between our two universities has continued to grow since the signing of this agreement. However, it is a little pity that the new coronavirus pandemic had made it difficult for us to meet face-to-face and to conduct joint research and our other exchanges as we used to do in the past. However, on the other hand, we believe that it is very meaningful that we are able to invite this time Professor Alexander, who is a world authority on disaster science, to take part in this meeting, which is a part of the Tohoku University Global Webinar Series. This webinar series is a new way of conducting research exchange between our two universities as we move into the post-coronavirus era. Professor Alexander will talk about his ideas for the post-COVID-19 era in respect of the disaster science field and hold discussions with other experts, students, and citizens, including researchers and students at our own universities. I expect that Professor Alexander tells us will be of great importance as we look forward to a future of coexistence with the new virus. So I'd like to thank you all very much for joining us today, not only those from our two universities, but also who has kindly joined us from all over the world. I'm very glad that many students, including our engineering students and other students from our universities, are able to avail of this valuable opportunity to hear from people from diverse backgrounds. Thank you very much indeed for joining us. Thank you.
Thank you so much, Professor Ricky. We are so excited inviting the giant of disaster science, Professor Alexander. So before the Professor Alexander speech, I would like to provide you with some background. Okay. So the pandemic is a sort of increasing the part of disaster science. Oops. Okay. Yep. Since around 1970, the science of disaster prevention has been criticized for its attempt to identify the reason for disaster. This as a result in fragmented the dialogues for each disaster. There has also been a lot of anxiety about the contribution to actual countermeasures. So, however, it's not easy to integrate the social and the natural sciences in disaster response. And we have not been able to find out how to do this. So then, 1993, the book, The Natural Disaster, was published by Dr. Alexander, who taught geomorphology, physical geography, the natural hazard, and the disaster studies, and developed both the multidisciplinary approach to disaster science. It's a very important book. So the book is a seminal work that bridged the gap between the natural and social sciences at that time. So since then, he has published the various important works, so many important works, and it's still influential among the disaster prevention, the researches around the world. So it's a great honor for us to invite him to this conference. So today's opportunity comes from two experts who has approached the disaster from different directions, from Sendai and from London. So one direction is from London to Sendai. The Professor Alexander visited the barn several times because he was interested in what was happened on the front line of recovery from the Great East Japan earthquake 2011. The other direction is from Sendai to London. So since 2011, Tohoku University, located in the center of affected area, has been working on recovering from the Great East Japan earthquake. So we are located quite very close to seismic center by Great East Japan earthquake and the tsunami. So we are involved in recovery process so many times. This is one photos which took part in the Kamaishi, the one with the most damaged municipality by tsunami. So then we found the importance of developing a comprehensive concept of recovery, but individual element of technologies. So we reached the research circle under Professor Alexander. Through the collaboration with UCL and Tohoku University, like Professor Ueki pointed out, his welcome speech will help with addressing the difficult situation based on our decade experience. Okay, so this is the background. So let me introduce the So today, we have Miss Mimako Kitamura, who has also worked on research project involved the disaster-affected areas with Professor Alexander. And like him, she graduated from the University of London. She will coordinate the questioning. So please use the chat room to ask any question that you may have. So please don't hesitate making the question during the Professor Alexander's lectures. And finally, Professor Shinichi Egawa, a member of the board of director of the International Research Institute for Disaster Science at Tohoku University, will give us his comment. As a medical doctor, the Professor Egawa is a key member of Japanese Association for Disaster Medicine and served as an associate editor for the journal, the Disaster Medicine and Public Health. He is also the head of local program committee for World Association for Disaster and Emergency Medicine, which called WADEM. I heard the WADEM 2021 Tokyo Congress was postponed to 2022 because of the COVID-19 pandemic. I believe that he is the best person to make the webinar, to make this webinar fruitful. So, Professor David Alexander, please start the lecture.
Okay. May I share my screen, please? I think you have to stop sharing your screen.
Okay.
If you could unshare. Still
yeah, yes.
Right, now I think we can share my screen. Hopefully you can see my PowerPoint now. Is that correct?
Yes.
Very good. Well, good morning, good afternoon, good evening, and konbanwa. I hope I got that right. Wherever you are in the world, it's an honor to be with you. I thank Professors Ueki and Onoda for their very kind introductions. And I really wish that I were in Sendai at present. However, we do the best that we can with the means that are available in these difficult times. Now, I wonder whether I should have called this Key Aspects of Emergency Planning and Management for Pandemics, or instead Key Aspects of Pandemics for Emergency Planning and Management. But we will see how the two perhaps fit together. Now, in 2008, November 2008, I went to a conference, and a man who is an epidemiologist, in fact, he was a professor at Al-Quds University in Jerusalem, stood up and said, My job is to tell you something you don't want to know and ask you to spend money you haven't got on something you don't think is going to happen. He then went on for 45 minutes to outline the scenario for a viral pandemic, and what he said was exactly what occurred 12 years later in the first half of this year. The scenario was not very complete for the recovery phase, but it was pretty comprehensive for the rest of the story, including not merely the medical and epidemiological side, but also the social and the economic side, and likewise the psychological side. Now, much closer in time, in fact, in March 2017, I gave a talk to school children. My university has a school, and I went down there and I talked to the children about pandemics. They were interested and they were studying pandemics. And in question time, a 12-year-old child said to me, "You said that it would take at least 6 months to create a vaccine. How could you be sure that the virus wouldn't mutate during that time so that the vaccine doesn't work?" I had no idea of the answer, none at all. I believe now that the answer is that if a virus is happy with its host, it doesn't have the incentive to mutate. And hence, if you have a well-ingrained virus that is replicating in human beings, then the vaccine should work, at least in the short term. But anyway, let's proceed. One of the first questions that we as academics have to deal with is what sort of a disaster is COVID-19? And that is really quite difficult. Sorry, I meant to go, there we go. Because most disasters, of course, are regional. They tend to be rather shorter in duration than this one is evidently going to be. And they certainly do not spread around the globe, not as single events anyway. So what does COVID have in common with other forms of disaster? Well, plenty of casualties, but on the other hand, there is no direct physical damage, even though there may be a great deal of economic damage. COVID obviously is global. Perhaps, therefore, we could call it a wave disaster because it ebbs and flows and it spreads and dilates. And that really makes it rather different to many other kinds of disaster, which might be abrupt or a ramp sort of effect, slowly increasing. Well, COVID will do that, but on the other hand, it may also decrease and increase. Now, we tend to use for this event a reference event from the past, which is, of course, the so-called Spanish influenza, which lasted 24 months. In Europe, that was 14 months, but it continued to spread around the globe. And that was called Spanish influenza quite simply because Spain at the time was one of the few countries that didn't impose censorship on its mass media, and therefore other countries were busily censoring the news about the influenza pandemic, while Spain in fact allowed journalists to comment on it. But the reality is it probably either originated in China or in Kansas, United States. We don't really know. Now, in the influenza pandemic, there were 2 or possibly 3 waves, and the second wave was worse than the first. Now, this time around with COVID-19, that has given rise to a great deal of debate. The latest we have on that is that scientists are beginning to say there is no wave structure to COVID-19. That is to say, it's a single wave. Well, I would dispute that in as much as that might be the way that the virus behaves, but what it is not is the way that people behave and societies behave. So I think we could well get 2 or 3 waves of infection as a result of the alternation between imposing restrictive measures and relaxing those measures. So let's not abolish the idea, let's not abandon the idea of a second wave or even a third wave, I fear, although of course we all hope that this virus crisis will end as soon as possible. The so-called Spanish influenza, in fact, lasted, as noted, a long time, one of the things that he did was to contribute to the end of the First World War, because more soldiers were dying of influenza on the front line of battle than were being killed by enemy action. We do not know how many people died in that episode of influenza. We believe between 50 and 100 million, and we believe mostly, well, we know, mostly in countries that had very poor healthcare structures, or perhaps none at all, where, of course, the number of victims simply was not counted. So most people died in poor countries, and that may well be the result that comes out of this in the final analysis. But there are certainly plenty of lessons to learn from the influenza of 1918, of 100 years ago, for COVID-19. If, for example, we look at the difference between the way that the influenza was handled in Philadelphia and the way that it was handled in Seattle. There were very restrictive measures in Seattle, and they were imposed very rapidly. In Philadelphia, there were not. There was therefore a much greater effect. Many more people were infected and many more died in Philadelphia, whereas Seattle managed to keep the infection rate under control and the number of casualties relatively low. And that is something we might ponder about in the present time, with all of the debate about whether to open up or to lock down again as things go on. One of the great preoccupations at the moment is how long will it take us to recover when finally COVID-19 starts to abate? Well, the news from the influenza of 100 years ago was that it took about 5 years. But on the other hand, we have to bear in mind that the world was recovering from the First World War, and the world and its economy and its people were very much debilitated by that. And some historians have suggested that the influenza managed to gain such a hold, not the least because the world was war weary. It was weary by the privation and the conflict of the First World War that in fact had reduced people's resistance to the disease in various ways. We also might ponder, we might consider the fact that the influenza, when recovery did occur around about 1925, that led into the Great Depression and the Great Crash of 1929. It is hard to say what effect it had on the Great Crash, which of course also had other causes, perhaps more important causes, but I'm quite convinced that in some way it was a factor. So let's get a little closer to the present. Now we're dealing with the second great outcome in modern times of a SARS infection, sudden acute respiratory syndrome. The previous one infected about 8,000 people in 29 countries over a 2-year period. In fact, it was a rather shorter period, but there was a flare-up again after May 2003, when it was thought at the time that the virus was fully brought under control, and so it lingered on until 2004. About 774 people were killed directly by that virus, and it's important to note that it was brought under control largely by concerted international action, and that is a lesson we really should bear in mind. Now, when it did finally begin to abate in 2004, much thought was devoted among epidemiologists and planners to what this meant for humanity. And in fact, over the period 2003 to 2009, there was a strong impetus to do research and publish papers on the scenario for a future pandemic, whatever the cause of it be. I think here we should restrict the debate to viral pandemics. There are other kinds and they are important. Ebola was something of a pandemic, so is HIV/AIDS, but the particular characteristics of a virus-induced pandemic are what we need to think about today. So the result of the research and the impact of SARS 2002 was to stimulate at the world level a period of intense pandemic planning. It was effectively kicked off by the World Health Organization's strategic plan of 2005, followed very rapidly by a United States pandemic plan, and strategic approaches were published and plans were published, for example, in the United Kingdom in 2011 and 2014. I recall at the time, 2005, I was in Italy, and a rather small town of 18,000 inhabitants, not far from where I am now, induced its emergency planner to do a pandemic plan in 2007. I suppose you could really call that pioneering at the local level. During this process of pandemic planning, influenza came to be feared more than other viruses. Now, viruses have two great characteristics, one of which is their infectiveness, and the other is their lethality. In other words, how easy is it to get the virus? And if you've got it, how likely is it that you will die of it? SARS 2002 was not highly infective by the standards of certain other viruses, but it was pretty lethal, and at times 1 in 10 or 1 in 9 patients were actually dying of it, which is regarded as a very high number. But on the other hand, that was balanced by the difficulty of getting it. Now, influenza can be highly transmissible, and therefore it can spread very rapidly. And moreover, in 1918 to 1920, people who got it often died very quickly, as a result of which there are certainly differences between influenza and SARS-type viruses. But are they important from our perspective today, which is the perspective of emergency planning? Some would say yes, because with the faster rate of infection of influenza, testing is much less important. There really isn't time to do it. Either you've got the disease or you haven't, and either you survive or you don't. Let's bear in mind that both with SARS and with non-seasonal influenza, there are intra-body defense mechanisms, namely your immune system, which of course may overreact and that may kill you. But there is no immediate cure. There are palliatives such as antiretrovirals and so on, but there is no immediate cure or no immediate safeguard. You are in the front line and you're exposed to both types of disease. And therefore, what happens next depends on the characteristics of the disease, which is something we only find out over time. And with COVID-19, we're still very much in the process of finding out. But the contrary argument is that no, in fact, seasonal influenza and a SARS virus such as COVID are not very different because the needs that they generate, the need for so-called social isolation, by the way, I wish we wouldn't call it that, is physical isolation. What we need is social togetherness, but we need physical isolation. So let's call it that, physical isolation. And all of the different measures and improvement of ability to treat people in hospital and reorganization of medical systems and bringing the fight against the virus into the community and all the rest of it. In that respect, whether it's influenza or whether it's a SARS virus is much less important or perhaps even unimportant. So here we are, along comes a virus. Currently, there is considerable debate about when it started. Evidently in 2019, when the mutation at some point made its way into human beings and began to thrive there. Was that in the beginning of the year or the end of it? As yet, we don't really know. There is debate over this, but there is debate over a great many other things. How infectious is it? That is very difficult to ascertain because we can really only calculate a reproduction number, that's to say how many people are infected by one person who's got it, on the basis of those who are known to have the disease. If we have carriers who are asymptomatic, in other words, nobody knows, including them, that they've got the disease, then perhaps we will not know that that is the case and we'll be underestimating the number of people who've got it. Asymptomatic transmission then is indeed something rather difficult to get to grips with scientifically and operationally. How lethal the disease is, the case fatality rate, of course, depends on the transmission rate from both asymptomatic and people with symptoms. Will there be another wave? Well, that is dependent on the medical characteristics of the disease, but also on the social, economic, and to an extent on the psychological characteristics of the population that carries the disease. So also we're finding that COVID, like other diseases, is specific to particular ethnicities, genders, and age groups. It appears to be have its greatest impact among elderly males and among people of minority groups. Now, it may not be that it affects minority groups for any medical reason, but rather for the socioeconomic reasons that they tend to be more in the front line. For example, if they tend to be poorer than the average and they work in those kinds of key jobs where they're perhaps working in hospitals or distributing goods, and they have a higher chance of infection. So this is a complex matter. And now we're all asking, well, do we get immunity? Is there herd immunity, that is to say, a collective form of immunity, or can you acquire, or do you innately have individual immunity to the disease? And if you have got it, how long does it last? And some of the bad news has been that it appears that immunity to COVID-19, including among people who already had it, might not last. Whether it lasts a matter of 2 years or 2 months is a matter of debate at present. And what does spread the disease? It's not merely the way that people behave among themselves. In other words, socially, there are clearly environmental factors, and many people are examining their souls to ask whether environmental mismanagement, poor stewardship of the environment, is one of the great factors. Finally, the efficacy of personal protective equipment. Have we got it? Have we got enough? Can we manufacture it fast enough? Is it of a high enough standard? Does it protect us well enough? Consider, for example, the debate over face masks. In much of Asia, they are routine and have been used for seasonal influenza for a very long time. In places with a very strong libertarian streak, there is sometimes enormous opposition to wearing a mask at all, even when it can protect people against the transmission of the disease. And it largely protects the person who is in front of the person with the mask rather than the person who is wearing the mask. And finally, of all, will there be a vaccine and will it help us? When will it come out? Will it be effective? Will it work? How fast can it be mass produced? Do you need 2 or 3 doses? And if so, over what period of time? How will it be distributed? And that is an enormous problem of medical ethics. And perhaps that is something that really does need some emergency planning, how to distribute any vaccine that is manufactured, because of course we won't have simply billions of doses all at once. And in countries also with a fairly strong libertarian streak in them, there is the question of how many potential recipients of the vaccine will accept it. And it is reckoned that about 23–24% of United States citizens will not allow themselves to be vaccinated. And with all diseases, we have the problem that if there are people who are not vaccinated, then it can still spread the disease. What we need is true mass vaccination to get the disease under control. So that's going to be an interesting problem that we're facing. Now, you might ask yourself, what parts of that problem can be tackled in advance of the next pandemic when it happens? And certainly things like medical ethics and the distribution of vaccines and what capacity we have to manufacture vaccines are things that we should be looking at now, not merely for this pandemic, but for potential future pandemics. Influenza pandemics, by the way, seem to occur on about a 30 to 40 year cycle. Well, no, let's not call it a cycle, interval of recurrence. Cycle I prefer not to say because it appears that the interval is quite irregular between outbreaks of the influenza, pandemic style influenza. Plus, of course, we're dealing with seasonal influenza, which generally is somewhat different. It may well be that COVID-19 becomes a seasonal disease in the end when it is less lethal, assuming it is less lethal in the future. So many uncertainties. And of course, the overriding umbrella uncertainty of what exactly is a pandemic. We have no absolute definition of that, and that might explain why the World Health Organization were reluctant to declare COVID-19 a pandemic when everyone knew that it was. So as we have no threshold to cross to make an outbreak of a disease, an epidemic, into a pandemic, an international or global epidemic, it is rather hard to say what is a pandemic and what isn't among diseases that have gone around the world in recent decades. So we knew a number of things beforehand. As I mentioned, in the year 2008, I went to hear the story, and by then it was fairly well entrenched. And in fact, I've been teaching it for the subsequent 11 years, at least once a year to students as part of our lessons in emergency planning. We knew the basic scenario for the pandemic more or less in full on the social, economic, medical, epidemiological, and psychological side. I don't think we really knew the recovery side to it. That really was rather opaque, and it hadn't been tackled as well as the rest. One thing we did know, and really important it is that the socioeconomic consequences were likely to be at least as serious as the medical ones. Of course, we haven't seen the last of either in COVID-19, but we are beginning to see just how serious the socioeconomic consequences are, and they are very grave indeed. We knew that the next pandemic would be, when we got one that was large enough, it would be highly disruptive to activities of all kinds, social and economic. It would cause major economic problems in a number of sectors, particularly travel, hospitality, tourism, and the arts and entertainment and cultural activities. There would be huge shifts in the pattern of demand for goods and services, and therefore there would have to be huge shifts in the supply of these things, and that would have a profound effect on supply chains worldwide, some of which would have to become very much faster and larger and more all-embracing. Others would simply dwindle away because the demand would disappear, at least in the short term. And as yet, because we have a fairly hazy idea of the recovery process, we don't fully know to what extent the changes are reversible and to what extent they are permanent. Some changes we would wish to reverse, in other words, those that are detrimental to the environment. Others we might not, but nevertheless, there are bound to be some enduring aspects in the social and economic and psychological fields of what is going on now with this developing pandemic. And we also knew that during the pandemic, there would have to be major behavioral changes in the population in order to get the thing under control and in order to limit one's personal risk and the risk that one poses to other people. And this, of course, would have knock-on effects into psychological relations and people's psychological state. So in managing the COVID-19 pandemic, it's been very interesting and instructive, country by country, given that really these things have been managed at the national level in most cases, to look at the question of how it was done. And by and large, in most countries, the sensible approach has been to make political decisions on the basis of hopefully the best available scientific information. Now, scientific information has been highly variable. We're dealing with a new and emerging threat, and knowing its characteristics is taking time and it's taking effort in laboratories, in data collection, in analysis, and in simulation. So some of the early scientific effort was simply wrong. It was off the beam. The answers were not right. And in other cases, the answers were, and very often still are, instead of yes or no, they are perhaps, and that can be very difficult. And one of the problems with this, though, is that in some places, at least perhaps many places, emergency planning and risk management, which are both well-developed skills with a 100-year history, tended to have been marginalized, ignored, and underfunded. Why at the table, then, do we have the scientists and the politicians, the decision makers, but not necessarily the risk and emergency managers, the people who make the plans. Many aspects of the plan are only partially or only somewhat dependent on the scientific information. For example, if it is a question of manufacturing and distributing personal protective equipment, how do we ensure that the equipment is manufactured and that the supply chains, the supply lines are kept fully open and increased in their rhythms and their reach, and that the equipment gets to whoever needs it by the circulation, also the information that is needed. I take as an example SAGE, which is a scientific committee for government advice in the United Kingdom that has 56 members. Now, 52 of those are scientists and 4 are politicians who will then bring the information back to the cabinet and the government. But what is notable about SAGE is that there are no emergency managers and no emergency planners and no risk managers on it. I think this is a major mistake, because what it does is it forces epidemiologists and medical specialists and politicians into the role of being risk and emergency planners and managers, and they do not have the training or perhaps the ability. They're not suited to such roles. And the curious paradox of this is that in many emergency planning situations, the scientific answers boil down to yes or no. Now, it may be a very provisional and a very uncertain yes or no, but it's often a case of do we or don't we? Do we lock down? Do we impose a full lockdown or a partial lockdown? Do we inhibit international travel? Do we refuse to accept international travelers from a particular country that appears to have a high infection rate and things like that? Well, of course, we need the scientific information and we need it desperately. But in the end, the answers are also logistical. They're also a question of matching needs with capacities, which also means knowing what our capacities are. And those are the preserve of the emergency planners and managers. Now, of course, there are many things we didn't know. How to recover from the pandemic is evidently something that we still have only a somewhat hazy idea about, and we will see how that develops from now onwards. Although in many respects, we're not in the recovery phase. It may be that in many countries, COVID-19 has abated, but in others, it is still working towards the peak, whereas in those that have seen the abating of it, until there is a general worldwide reduction in infection rates, then you simply cannot be sure that we are on the mend, that we're moving towards the end of it. So in that sense, we don't really know to what extent a potential second wave of infections, a growing rate of infections, is likely to be important. We do have better emergency management in many countries, which means better organization of hospitals to deal with infections. Plus we have experience now, direct recent experience of imposing lockdown, of shutting down activities that can lead towards the transmission of the virus. But we still don't know all the details about the virus. Now, one of the things that was rather poorly dealt with, I won't say it was absent, but it was poorly dealt with in the plans that came out over that period of intense planning, 2005 to 2013, was the effect of a viral pandemic on care homes. Now, these are places where particularly elderly people are nursed, or possibly also sick people. Many elderly people are not in good condition. They're especially vulnerable. And these institutions can be very seriously affected. For example, in Milan, in Italy, there were 400 deaths in one large care home. And one of the reasons for this was the discharge of hospital patients into care homes without testing them to see whether they in fact had the virus or not, which rapidly spread the virus among people who are unlikely to survive it. In the United Kingdom, there are many agency staff in care homes. They moved from one care home to another, and in so doing, they took the virus with them. That was not their fault. That was the fault of the way that the system was planned and managed. I would say that the people who did that were, the care home staff were quite innocent in their way, but an entirely different kind of planning to manage the situation was required and wasn't present. So what we have found out, and what should have been fairly apparent from understanding and analysing the situation, is that top-down national approaches are all very well, but really without that capillary organisation at regional and local levels, they're not going to work. If you look at the COVID situation in the United Kingdom, which you can do fairly easily on the website of the newspaper, The Guardian, if you can find the right page, there's always a map and a list of the different local authorities around the country and their infection rates. And what you find is the infection rates are highly variable from place to place. And this is really indicative of the need to apply a local solution. Now, we know that from emergency planning and management generally, because no matter how large the disaster, an enormous tsunami that affects the entire Indian Ocean basin, what you like, it's still something where the theatre of operations is local. And that is also the case with COVID-19. Now, take another example, which is a very small town called San Costantino Albanese. It's very much a backwater. It's in Basilicata region in southern Italy, and it is totally forgotten. Nobody ever goes there except the inhabitants, and never ever thought about. And it became a focal point for COVID-19. But one thing it had, it doesn't have any industry, it doesn't have much in the way of employment. Many of the people who live there are elderly, the population is very small, and there are high risk factors. But it managed to get things under control. And why was that? Well, it had a good, local, robust civil protection system where they could immediately get to work and impose the measures that would quarantine the area, look after people who had the disease, test those who might have it, and ensure that people were as safe as they possibly could be. And that was a simple, very humble, local demonstration of the importance of being prepared locally and also bringing this into the community. Another thing that has been very apparent about COVID is the importance of planning for supplies. Now, supplies include things like ventilators for those who need assisted breathing, masks, gowns, visors, hand gels, disinfectants, and so on and so forth. And if we don't have them stockpiled, how quickly can they be manufactured? Who will manufacture them? And how are our supply lines going to manage with that? Terrible mistakes have been made in the UK over that, where, for example, they sourced 400,000 gowns from Turkey, and when they arrived very late, they turned out to be unusable. That is not the sort of situation that should occur with the right sort of emergency planning. So for the next pandemic, we need to be sure that we have the arrangements worked out. If we don't have the stockpiled gowns and masks, then where exactly are we going to get them? Who is going to manufacture them in record time? And how are the supply chains and the distribution chains going to work? How will we have the information on who needs them and the priorities in that? And these are all emergency planning questions. And how do we identify also the zones of special vulnerability, particularly care homes, and how do we deal with that? The answers are, as they say, not rocket science. They are eminently solvable questions, providing the solutions are done on time or in time. So what we find as we look around the world is that leadership has been highly variable. In some countries, and I'm not going to name names, it has been arrogant and denialist. And that really is absolutely the worst thing that could happen. In others, it has been ignorant, a reluctance or a failing to consult experts, or it's been indecisive or erratic. And indeed, one of the great tragedies of COVID is that one thing we needed to know from the past through our emergency planning is that once something like this starts, you should recognize the sign and get to work on it immediately. Rapid action saves lives. It is estimated, for example, that 20,000 people in the United Kingdom died because government action was too slow, bearing in mind that it could have been faster and saved those lives. Now, that cannot be demonstrated uncontrovertibly, but it does look highly likely. So we might regard that as a form of negligence, failing to act when there is an imperative. Another question concerns vested interests, which are mostly vested economic interests, because of course there are enormous costs in shutting down activities, and there will be lobbies against doing that. But that in its way is exploitative. There isn't a direct sense of balancing human lives against economic questions. It's much more complex than that. But nevertheless, there are instances where welfare has got to replace economic activity. Now, over time in Europe, and particularly in the United Kingdom, there were 3 exercises. The European Union used a fairly large exercise in 2005 in response to the initiative launched by the World Health Organization. That was largely designed to test how cross-border collaboration would work in a pandemic. And the footnote to that is it didn't work very well, at least not in the early stages. In fact, it worked appallingly badly in the European Union. It is now rather better, but largely because the leaders were justifiably ashamed of the way it worked in the early stages around March and April. And yet the information was there in the report on Exercise Common Ground. The United Kingdom held Exercise Winter Willow, which was a very large exercise, and then a tabletop exercise, although that too was large because it lasted 3 days, in November 2016. The report for the latter, Exercise Sickness, was suppressed. It was eventually published in the midst of COVID-19 by a newspaper, and it made very interesting reading. And what it did was to identify a whole series of weaknesses in planning. Now, the United Kingdom had been identified, along with the United States, as being top of the class for emergency planning for pandemics by the World Health Organization as recently as 2019. Well, I hope that they are blushing over that, because in fact, in both cases, the management of the disease has been very poor. And at present, it doesn't look as if it's going to get much better. But what we then see is that, yes, there were the plans, they were not kept up to date adequately, but above all, there was a gulf between the planning process and the ability to implement the plans. And this is something we really must take on board as a lesson. You cannot have plans that are perfect and a reality that is absolutely imperfect. In other words, the plans have simply got to connect with the reality. People will have needs, the emergency will generate needs, the plan has to know with foresight in advance as much as possible how those needs will be satisfied. So what we then found was that countries tended to retreat behind their own borders under the guise of lockdown, which rather reduced the degree of international collaboration, although thankfully that certainly went on in the sciences, and that is something we need to be grateful for. But it was really sad to see international organizations marginalized in that process, particularly the World Health Organization, which may have its defects, but there is no time like the present when we need the World Health Organization as much as we do at present. The first reactions in many places, including the United States and the UK, and perhaps also China, were a form of normalcy bias and what the psychologists were called unconflicted inertia. Let's just boil that down to disbelief. In other words, it was time before they realized, time went by before they realized that really something had to be done. The initial reaction was to assume it can't be that bad. Well, it is that bad, and it was that bad. And that needed to be recognized a lot earlier, which meant that the transition from giving priority to the economy to giving priority to the healthcare situation needed to occur earlier, despite the risks and the impacts upon the economy. So what should have been done was to recognize the signs and react quickly to them. We therefore need to build into future pandemic plans a better ability to recognize signs, make a judgment on the basis of them, and institute quick reactions In other words, to limit the spread of the disease at early stages, given that the spread is geometric. In other words, once it's above that R number of 1, a single person will infect more than one other person, and we therefore have the proliferation of the disease very easily and very quickly if we don't contain it and keep it under control. This obviously means learning quickly from other countries, and if the progress of the disease follows certain patterns in those countries, then we have to ask immediately, well, will it cross national borders, and therefore what do we need to be doing? Strong measures need to be imposed at an early stage, and in so doing, that can save a great deal of economic hardship, and stronger measures at a later stage if we can keep things under control. And the more I look at that and the way it was done, the more I realize that in fact it is little more than standard epidemiology, albeit on a rather larger scale than it has been for smaller outbreaks of disease. But we had the scenario. Now, a generic scenario for a viral pandemic is something that we have in a pretty robust form, and we've had it since the mid-2000s, and it has been built upon, debated, added to with scientific information ever since. So we really could not say that at the start of COVID, we didn't know what would happen. But as I say, it is one thing to have plans, and it is another thing to make them operational. So in fact, we need to place a great deal of emphasis on doing exactly that. That's to say, beefing up our plan on the basis of scenarios and ensuring that we're able to activate the plan when we need to. Now, many people from Napoleon to General Eisenhower have said that in warfare, plans are useless, but planning is indispensable. In other words, it's the process that matters, not the document. The process is one of understanding the phenomenon and the needs that it generates. And that is exactly what we have to do, but in an operational way. In other words, to make the connection between emergency planning and emergency management in advance with the aid of foresight. So where will that lead us in the future? Well, we do need to start planning fairly fast, because planning is a continuous process that needs to go on all the time. It doesn't stop when you have a document. There is contingency planning and there is immediate planning for the next 4 hours even, as well as the basic plan from which we hope we are working. But we need to be ensured that we're not perpetuating or enhancing, increasing inequality in the world. That will not be good for anyone. We need to ask who has exploited others during COVID, because there are people who've made a great deal of money out of it. We need to ask whether we can bend our planning and our policies and our procedures to make the future greener. And there is an imperative in that. And will it happen fast enough? Will there be bigger and worse pandemics? Already, the potential for an influenza pandemic has been identified with the discovery of a new mutation of H1N1 virus. And that is more than seasonal influenza, which in its own right is a bit of a pandemic on a smaller scale usually. So the next one will probably be influenza. Therefore, let's go back to our influenza plans and see what we need to be ready with. Of course, one of the problems with that, by the way, is that the antivirals that were stockpiled eventually ran out. That's to say, they reached their use-by date where chemical changes within them would mean that they shouldn't be used anymore. They therefore had to be destroyed. That also cost money. But there was a reaction to the fact of having purchased a great many medicines, stockpiled them, and then having to throw them away and destroy them. And that was felt to be uneconomic. Well, it may well be uneconomic, but the fact is, if you really need these things, at the least you should be able to manufacture them very, very quickly if you're not going to stockpile them in adequate quantities, because this is a reality, the reality of potential future infection. And if we look back over very long periods of history, let's remember that bubonic and pneumonic plague were highly recurrent things. So were things like smallpox, cholera, typhus, and typhoid. They were highly recurrent, which is to say there are often quite short intervals between one major outbreak and another. And bubonic pneumonic plague, in fact, in the 1340s and early 1350s, killed an estimated 1/3 of the population of Europe. Well, we wouldn't have that now because we do know how to treat and cure and deal with those particular issues. But of course, with viral pandemics, we're dealing with something else that is also lethal. So the palliatives and the recovery, medical ethics are something that really need profound thought. When there is a vaccine, who will get it and who will get it first? Who is it destined for? Who will receive it? Who will accept it? Will powerful countries try to monopolize vaccine stocks? They've already tried to do that with palliative drugs, and that is in no way ethical. Is any country prepared to be generous in that the world's poorest countries are likely to bear the brunt of COVID-19, not merely in terms of casualties, people who get the disease? For example, it is reckoned that in the poor quarters of Mumbai, half of the population has got COVID-19. But will countries be prepared to collaborate and to be generous in order to ensure that the socioeconomic effects are mitigated in poor countries? So what will happen to aid for developing countries at a time when the economies of rich countries are depressed by the aftermath of the virus? So, a take-home message: emergency planning and management hold the key to the control, at least of some items, some articles connected with pandemics. Obviously not all things. I'm not suggesting that we don't need science. I'm not trying to marginalize the health sciences. We need them absolutely. But on the other hand, there are things that we really need to improve our performance on connected with emergency planning and management, in which they are not directly or totally dependent on the science behind the pandemic. So we need to be able to work out in advance what needs are going to be in a pandemic, in the recovery from this one, in the next pandemic to come along, in order to plan in advance how to satisfy them, because one of the great characteristics of the early months of dealing with COVID-19 was the frantic improvisation that went on. And in very many instances, it should never have been improvisation, because improvisation is an indication of negligence instead of foresight. We also need to ensure that communication is robust, it is honest, and it is accurate as far as possible. Now, the scientific knowledge may be uncertain, in which case the communicators may need to communicate that uncertainty, but they need to be open, honest, communicate a solid, clear, unambiguous message as far as possible, and that enables rather than inhibits dialogue with the public. The Prime Minister of Italy has so far done that pretty well. As a result, his popularity has been fairly enormous. And it has involved being very honest with the public about the problems as well as the solutions, and not trying to conceal anything, but also setting a good example and trying to ensure that people follow that good example and explaining to them why. So we need to treat the public as grown-up people, and perhaps that will induce them to behave as grown-ups as well. So a clear, precise and flexible strategy in both managing the event and communicating the management of it. And that also is something that we can work upon in the planning process and at the planning stage before we need to use it again in the next pandemic. And flexibility is important because needs evolve and situations evolve, but with the scenario, perhaps many of those needs we can anticipate by understanding what is likely to occur and where and what needs will be generated at certain points during the pandemic process. So during a webinar yesterday, I said that I thought COVID-19 is an existential threat. Now, some people didn't really agree with me, and perhaps it was because time was very limited. I didn't have time to explain exactly what I meant. I think they meant that I thought this was something that could wipe out humanity. Well, I don't think so. Now, for each of us, if we get COVID and it kills us, yes, of course, it's an existential threat on a personal level. But there are reasons why I think COVID-19 is an existential threat on a different level. And those are that it is telling us something very important about the way we live and the things we need to do in order to live better as a human race. One of those is that universal healthcare is essential. The Nobel Prize-winning economist Amartya Sen once wrote a very persuasive piece about how universal healthcare can save a country from serious economic problems and difficulties associated with simply the impact of disease and illness and so on, or short longevity of human lives. And it is therefore not only a human right, but it is an absolute essential. Solidarity and welfare are absolutely necessary, which means a form of collectivism which counterbalances the individualism which has been very much an artifact of the technologizing of society. Technology has bred individualism, and that isn't good. We now need to reorientate the technology to breed more collectivism. And in so doing, the collectivism must feed into environmental protection. Really, that is all I have to say, but one afterword about it is I don't have up-to-date statistics, and that is a great pity. Perhaps no one can count anymore. But during the first 3 months of the year, it was estimated by Times Higher Education, which is a magazine for universities and so on, that there were 6,600 scientific papers published on COVID-19. That's a rate of 67 a day. The number, I suspect, is far, far higher now. So if we're going to do some reading, we're really going to have to work very hard at it and perhaps be very selective as well. But at least academics and scientists and scholars are looking into this in a big way and not merely in the medical professions. So we produced a report written by me on the basis of suggestions from very many people, where I've tried to put together a generic scenario in great detail. It's about 20,000 words, called Building Emergency Planning Scenarios for Viral Pandemics. In other words, some of the things you might need to think about if at any level, from local to international, you were trying to put together or even just to improve your emergency plan. In other words, what not to forget and what is likely to happen in the next pandemic. So at that point, I will stop and hope that we might have questions. Thank you very much for listening, and go choshu arigato gozaimashita. Thank you.
Thank you so much, Professor Alexander. I think it's a very elaborate and thoughtful lecture for us. So, well, I think it's a time to question and answer. So please, Ms. Kitamura, to coordinate the question and answer.
Yes, Professor Alexander, thank you very much for the precious talk. We have many listeners from all over the world joining us today, and I know many of you have a question for the Alexander. So we would like to have the Professor Alexander answer as many of your questions as time permit. So David, what kind of question would you like to have? I think with the chat box, we have already talked about many questions. So would you mind to take one or two from there?
Yes, indeed, delighted to. I'm looking at present questions about care home facilities, group homes, where large numbers of people must live together, and where it's very important to communicate with them. What should we do to safeguard them? I think in some countries we initially saw a situation where things were very bad and things went very wrong, and subsequently things were put right. So I think there are actually lessons there from actual cases in different countries. One of the lessons is not allow infections into these places and ensure that the appropriate measures are taken within them. For example, in the United Kingdom, the use of agency staff where they went to several care homes really needed to be stopped immediately so that they didn't take the virus with them. Visits to care homes have to cease. The staff of care homes need to be protected, which means they need to be tested for the virus frequently. Bearing in mind, it's not just a case of testing people once, it's a case of testing them again and again to ensure that in the meantime they don't get the disease and they don't pass it on. And that care homes are as well protected with supplies of things like gowns and masks and visors and gloves and so on that can be used once and then thrown away, as hospitals are, that they have the same status as hospitals, and also that we don't discharge people into care homes without giving them tests for the virus, at least basic immunity tests, because otherwise we risk introducing the virus. We need to do everything we can to stop introducing the virus into the care homes. Now that is particularly difficult for certain kinds of patients. For example, if we look at disabilities, then there's a great issue about, for example, people with autism who might need to go out. And when we have lockdown, they really do need exercise and to go out into the open wherever possible, perhaps with their carers and so on. Lockdown can be prejudicial in various ways to a number of people with various kinds of disability. So that is something we need to do some specialized planning on. And I haven't seen much of that. I certainly haven't seen enough of it. There is now a growing literature, I think probably about 50 papers or so have been written recently on disability and COVID, but mostly those papers are about the impact of COVID on people with disabilities, not so much the logistics and the psychology of trying to care for them during this pandemic. And that needs some study and some measures and some planning. Not a very good answer, I fear, but these are very intractable problems.
Yes, Nana-san, I think that question was from you. I think the nurturing house system is a very important issue for our future thought. So we would like to send the next question. So David, would you pick up some question from the chat box, please?
Yeah, I don't have time to read through them all at once. I'm looking at one here that says, regarding top-down approach, the Japanese government makes the travel risk level for the whole world. Almost all countries are at level 3, recommendation of cancelling travel, and others are at level 2. This has great problems about, for example, students who want to go and study abroad and have perhaps made arrangements to do so. The importance of being flexible. Well, I was very critical about the UK government, which put about 2 days ago a blanket ban on connections between Spain and the UK. Now, there have been increases in COVID rates, infection rates in Spain, but actually only in 2 regions. A lot of people travel to the Spanish islands where infection rates are currently very low. So I think that was an illustration of what the questioner is suggesting here, that in fact we need a more flexible approach. We tend to see these, you might almost call them knee-jerk reactions. We see these unthinking reactions where you put a blanket ban on something, and that really isn't necessary. There have been travel bans during this where entrants have been banned from a country that has a lower infection rate than the country they're going to, which really doesn't make sense. So I think this needs to be done with care, because in fact we do live in a world where we've become increasingly dependent on international travel. In terms of students, my university is doing what it can to try to ensure that those who can't get to London are able to study there remotely. Personally, I don't think that there is any substitute for being there personally and physically. Maybe we need to do it this way, but I don't think it is as good as actually being physically in front of someone where we can have a proper conversation, not mediated by a screen, which is one reason why I wish I were at Tohoku University talking right now. But anyway, we do what we can. There are interim solutions if we can't move. but we also need to be concerned about what does this mean for future international travel, given the profound impact on air travel. Now, you might say, well, air travel is not good for ecology, for greenness, for the environment anyway, and it's good that there's less of it. Well, perhaps so, but we need not to be under duress if we're going to determine how big the civil aviation sector is going to be after this. Certainly a degree of international travel is quite necessary. It's very good to see scientists going abroad and working with other scientists in other countries. It really does help the moving forward of science if you could do this in person rather than having to do everything electronically. We should also be concerned about dependency on electronic measures. Last Thursday, I dropped a cup of coffee on my computer and ruined it. It was the most expensive cup of coffee I've ever had in my life. I'm still waiting to see whether specialist experts can get my data back, having extracted the data card from the machine. But that was catastrophic for my work. But there we go. Anyway, next question.
Excellent questions, but I'm very sorry, but it's time to go. So this will be the last question from everyone. So David, would you like to talk about the cascade disaster connected with the COVID-19 for that?
Right. I haven't emphasized cascades in the report, which you can download. Let's just share the screen again in case you didn't get the address there. But you can download it and look at it. I didn't emphasize cascades, but in point of fact, much of it is about cascades because I think we need to do considerably more research on exactly how COVID-19 does cascade and what the implications are of that. I think we will be doing that, and I think that is really important that we do it. But you can immediately see some of the elements of the cascade. For example, there is likely to be a mental health storm as a result of COVID. There are people who are desperate for many different reasons. One is being cooped up in difficult circumstances. Another is that some people have mental problems anyway, and these will be made worse by lockdown and everything else. Another is that people get desperate because they lose their jobs and so on, particularly in the most affected industries and so on. So that is one aspect that then what are the implications of mental health problems and so on. That's just one example. There are many others and there isn't time to talk about them, but I think we need to look very carefully for the purposes of emergency planning about how we can devise, determine, shape the cascade so that we can anticipate needs that are not obvious, and there are many of them in this situation. Thank you.
Thank you, David. So to all of our listeners, so finally, I would like to have a comment from Professor Egawa of Tohoku University. So Professor Egawa, thank you for your time.
David and everyone, thank you very much for your very interesting talk and very active listening and questioning. And I'm a medical doctor and a surgeon, and I see the many similarity between the disaster and diseases. And like surgery, this is a very acute phase, so that after the operation, the patient should have a recovery phase and also the rehabilitation phase, like a disaster. And I think that the flexibility that you mentioned in the time of emergency planning and the dependency or cascading of the many effects after disaster is very similar what will happen in a human body after a surgical operation or disease like COVID-19. COVID-19 is a kind of very severe inflammation in the body that was caused by the virus, but the body itself created the disease. so that pneumonia or thrombus in the vein, that the bloods are clotting in the vessels, makes the organ failure or mental health illness. I didn't mean any psychological effects, but many other side effects, long-term side effects after the COVID-19 is already recognized. So I think that, as David said, the recovery phase from the pandemic are not well studied at all. So that David mentioned that more than 6,000 papers were published in only 3 months, but they are all acute phase about the characteristics of the disease. However, they are not focusing on how the society or how the human being can recover from this pandemic. It will take months, years, and years. So the long-term consequence after a disaster, even pandemic or Great East Japan earthquake or many other disasters, has a long-term consequence after it. So that our research should focus on this long-term phase, how we can better or how we can quickly recover from the damage of the disaster. You know, 100 years ago, we had a Spanish influenza, as David said, but probably nobody remembered that pandemic after the COVID-19 occurs. So the people forgets within 100 years what happened 100 years ago. And also the World War I, World War II, the many consequences, the people are moving to one disaster to another chaotic situation very easily to forget the previous lessons learned. And we are saying the lessons learned, very similar lessons learned again and again. So that we should make this lessons learned to the knowledge to be transduced to the next several generations. So I think the science is needed to make the recovery from this disaster. For example, the Tokyo Olympic and Paralympic Games will be planned for the next year, but it will be nobody is expecting it is for so sure, but if it is performed, it will be a good opportunity to recover from the social and psychological damage from this pandemic, that the world can be united and we can visit each other, so that this is not probably the final point, but this is a good experiment, so that the flexibility for coming in and going out internationally is a test case using the Olympic Games. So I think that kind of social experiments can be a very good way of studying the reconstruction phase or recovery phase from a disaster. Thank you very much, David. I appreciate your very nice lecture. Thank you.
Thank you very much. It's been a pleasure and an honor to participate.
Thank you so much. Thank you so much for Professor Egawa for your, how can I say, connotative comment. Also, we are very appreciate for many interesting questions from the audience. I wish there another, how can I say, the chance to answer or make a comment to all of them. And also, thank you so much for Professor Alexander for the great lecture. It's so rich, yeah, and we are so honored to have such kind of very interesting and important opportunity at this point. So, but how can I say, the richer time, the faster it passes. So I'm afraid it's a time we have to close this event. So thank you so much for everyone. Thank you so much, David. Thank you so much. Thank you so much for Professor Igawa, and Kitamura-san, and also Professor Ueki, and the audience. Thank you so much. So thank you for goodbye. Thank you.
Keep in touch,
Yeah,
everyone.
keep in touch. Yeah.
Bye.
Yeah.
Bye-bye.
Bye.
いや、ありがとうございました。So,
お疲れ様でした。
ありがとうございました。
So this is the end of Tohoku University webinar. Thank you for participating in the webinar. If you have a time, please answer the question later. That we are forward to hearing your feedback to today webinar survey. We will send the URL for the survey after your how can I say registered email address. So thank you so much. So goodbye. Bye. ありがとうございました。